A male patient presents with progressive bodily rigidity and kyphosis. I am showing you the pelvic radiograph. Describe the findings.
Right, so the antero-posterior pelvic radiograph demonstrates extensive sheet-like and linear columns of bone density calcification and ossification surrounding both hips. Thick bridges of heterotopic bone are visible extending between the pelvis and the proximal femurs, leading to complete ankylosis and joint fusion. Additionally, dense paravertebral ossification is noted bilaterally, causing fusion of the visible lower spine and sacroiliac joints. Orthopedic surgical hardware from a previous left hip internal fixation is present, likely placed in an attempt to improve mobility. The femoral necks appear shortened and widened, and the bones display generalized osteopenia from severe disuse. The appearances are classic for Myositis Ossificans progressiva, also known as Fibrodysplasia Ossificans progressiva.
What is the pathogenesis, clinical course, and genetic background of Fibrodysplasia ossificans progressiva?
Fibrodysplasia ossificans progressiva is an extremely rare, autosomal dominant genetic disorder of progressive heterotopic ossification. It is caused by a heterozygous mutation in the ACVR1 gene, which encodes an activin receptor type 1 receptor, leading to overactivation of the bone morphogenetic protein pathway. The condition typically presents in early childhood, often by age 2, with recurrent episodes of painful subcutaneous soft tissue swelling or flare-ups. These inflammatory swelling episodes gradually mature into hard heterotopic bone, replacing skeletal muscles, fascia, tendons, and ligaments.
Explain the anatomical progression, typical deformities, and severe complications associated with this disease.
The progression of heterotopic ossification follows a characteristic pattern: cranial-to-caudal, proximal to distal, and axial to appendicular. Involvement of the cervical and thoracic musculature leads to severe neck rigidity, torticollis, and progressive thoracic kyphosis. A highly specific, pathognomonic congenital deformity is microdactyly of both great toes and thumbs, which is present at birth. Other anomalies include short metatarsals, monophalangism of the first digit, and hallux valgus deformity. Severe, life-threatening complications include thoracic insufficiency syndrome and respiratory failure due to chest wall muscle ossification.
What is the significance of the previous surgical hardware visible on this patient's radiograph?
The surgical hardware reflects a historical attempt to surgically release hip joint stiffness or treat a pathological fracture. However, surgical trauma, intramuscular injections, or biopsies are strictly contraindicated in these patients. Local trauma triggers a massive inflammatory flare-up, leading to rapid, accelerated heterotopic bone formation at the site. This serves as a critical warning that surgical intervention must be avoided, as it worsens the patient's stiffness.
Discuss the management, diagnostic guidelines, and how you would manage this patient as a radiologist.
Currently, treatment is primarily supportive and focused on preventing trauma and managing painful flare-ups. Investigational agents, such as palovarotene, which inhibit the bone morphogenetic protein pathway, are showing therapeutic promise. As a radiologist, I would immediately note the classical features of Fibrodysplasia ossificans progressiva and warn against any diagnostic muscle biopsy. I would recommend referral to a specialist multidisciplinary team, genetic testing for ACVR1 mutations, and advise strict avoidance of fall risks or intramuscular injections.